Hi, this is Jon Roffman. I'm a managing principal of ZS Associates Oncology Vertical. I'm joined here at ASCO 2018 by Dr. Debra Patt. Dr. Patt is the Executive Vice President of Texas Oncology and the Director of Analytics for US Oncology. Dr. Patt, do you believe that at some point all patients should be tested with next generation sequencing? And if so, what will it take to get there?
So I do think that at some point we will get to a place where all patients would benefit from next generation sequencing. I think someday we will get there. As technology continues to emerge and we have companies that develop drugs that identify highly actionable targets that have really active therapeutic interventions, and those become more and more prevalent, I think that more and more patients benefit from next generation sequencing. So I think that cancer innovation needs to continue to progress. We need to continue to identify drugs that act in this space. I also think that cost needs to go down for next generation sequencing, and technology will get us there. Technology will allow us to disrupt the price, at least for candidate genes. And I know there are a lot of various different types of next generation sequencing, but at least for candidate genes, the price will be disrupted and come down and become faster. So those things will make that better. And then the piece around guidance is critical. We need to make sure that there's guidance in the oncology community about where to send testing, because as we have a lot of variability between next generation sequencing assays, there is a lot of hazard in potential bad actions. So for example, let's say that I, as a community oncologist, see a patient with non-small cell lung cancer. And I decide that I'm going to give them a first treatment. And so I start that first treatment because everyone who has cancer wants to get treated right away. And they're responding, and it's 2 weeks in, and I say, you know what, we want to do molecular phenotyping. So I'm going to order a cell-free DNA assay on you to do molecular phenotyping to understand better what therapeutic interventions are possible.
Right.
And I send that cell-free DNA analysis. It's a terrible time to send cell-free DNA analysis when someone is likely responding to therapy. The best time to send it is when they have a heavy burden of disease and they're untreated or actively progressing, because then the cell-free DNA in the bloodstream is going to be more representative of actionable mutations instead of picking up noise like clonal hematopoiesis or other molecular aberrations that you're going to see when you test cell-free DNA. And today, we don't have a lot of guidance around that space. I would say that there's variability in the understanding of the role of some of these tools that we have before us. And so I think that there's a large role for ASCO and other organizations to help to provide that guidance to clinicians.
Well, thank you so much for your time, Dr.
Thank
Patt.
you.
It's been a pleasure talking to you, and hope you enjoy the rest of your ASCO.
Thank you.